the work you have done. You are bringing out issues related to children. And when you talk about children and mothers, everybody wants to listen to you. So I know that many people are here keen to hear what you discuss. I want to start with the issue of appropriate medicines for children. We are going to have some maybe 20 or 30 minutes of discussion and discuss these things freely. These are not questions like the typical Bible. Appropriate medicines for children. Where did this concept come from?
Yeah, it has been an ongoing concept, and but it was much more emphasized after the World Health Assembly, after the 6 years World Health Assembly, which highlighted the importance of having better medicine for children. And from then, people started rolling out how to achieve this.
Okay. You seem to say that it all started high up with the World Health Assembly, and perhaps with literal inputs from the lower levels. Do you comment about that?
Well, I don't think I can say that, because the World Health Assembly includes representatives from different countries. So how it was reached was through consensus after discussion, and after people have had raised their experiences that they came up with this concern. So it was actually kind of participatory.
The question is there real evidence that we are losing children or keeping them in hospital longer because of inappropriate medicine?
Yeah, there is evidence that actually children vomit the medicines, and if they vomit the medicines, what happens? The dose will not be complete. There is evidence actually that some children died in Ethiopia and after taking plasquantel. So that's the evidence, and the evidence that people have talked about has much to do with not mortality, but the practical difficulties in administering medicines to the children. And in that regard, it becomes kind of given that if children vomit the medicines, if children choke because of the medicine, it's not desired.
You know, I tried to do some literature search on children dosage formulations, poor treatment outcome. Did you catch any?
Yeah, I tried and I couldn't.
You couldn't?
Yes.
Yes, so there could be an issue there as we push the policy for child.
I would say that.
Yes.
That this is where we need to focus on outcomes.
Okay. Now you are moving forward to your conceptual framework, and I understood your story to be an analysis of the continuum of policy initiation, development, and implementation. I want to hear some of the factors which support processes of policy initiation, policy development, and implementation.
Yeah, well, there is a lot of discussion about how policies get on a policy agenda. And of course, there is a lot of literature describing how one of them is the interest, and if the key interest groups would be able to appreciate a problem, then they would be able to initiate discussions about it. The other factors include resources. People, for example, it's like you go to the hotel and you want to eat food with your children, and then there are 3 courses: the starters, the full course, and then the desserts. Then you start telling children, by the way, we are only on a full course, and therefore we have to share the plates. So even in policy, people will warn you early enough that when you go into that area, the cost is high, and we shall not be able to go there. But also the other factor, which is I think very important, is the fact about knowledge. The knowledge people have, the appreciation they have about a certain problem. And in this case, I can argue that we have not yet appreciated much about the children's needs. And this question you have asked me, I was asked the same question some time back, that why are you going to do this kind of thing? So it shows that we have not appreciated the kind of problems we have. The other thing is, conservativeness. People want to do things the way they have been doing for many times. And it's very clear that although syrups are more expensive than disposable tablets, many of the health workers are prescribing actually syrups, not disposable tablets.
Going to still the general intentions of your study, what did you foresee as the major contribution of this study?
Yeah, the major contribution of this study is to bring to light the question of children. When I was even looking at these clinical guidelines, I did not see many names of pediatricians. If there is anybody who knows it and who has gone through, he can tell me. But there are not so many. Secondly, there is a section for children, a whole section for children, which includes newborn care. Only a few medicines are highlighted as disposable tablets, which means that much as evidence shows that actually there are better medicines which can be used to treat children, it has not been included as a priority. So
you bring out children to the forefront of policy. Did you develop any hypothesis? I do appreciate that most of your studies are descriptive, but did you bring out any hypothesis?
No. I didn't have an hypothesis.
Most researchers would want to hear some hypothesis.
Yeah, because I didn't feel it was necessary. Given that most of the methodologies I used were qualitative and they are more on research question arrangement than actually a hypothesis.
Okay. So, thank you for that. Let's go to your sub-study 1, which is largely qualitative. And you seem to observe that the existing policies do not seem to highlight medicines for children. Why do you think they don't? From the discussion, I tried to read through the discussion, and they would still want some emphasis on some issues. Why do you think that much as there has been discussion at the World Health Assembly, a lot of deliberation is by professionals, the policies don't seem to catch this thing?
Yeah, one of the things I wanted to look at was to say this is there is in the whole section of the clinical guidelines, they have provided aspects of children. Actually, there is a big section on that. And they have also talked about how children should be treated. In this guideline, they are talking about weight, which is calculated in kilograms and grams of the medicine. I had thought, because the concept of child-sized medicines was a global concern, I had thought that because the concept of appropriate medicines for children was of high concern, then they would be reflected in the policy documents. But we don't see them coming out explicitly. In the guidelines, you don't see people talking about issues of swallowing, for example, although guidelines are given for other things, other precautions, but they are not giving concern about the question of palatability of the medicines for children. And I think that's where my argument is coming from. Although the issue of weight is really well taken care of.
I will again reflect on the conceptual framework. Between evidence and policy, what stands in between?
In between evidence and policy? Yeah, there is implementation.
It's implementation, yes.
But also integration of the evidence into policy.
Yes, integration.
Yeah.
Who does the integration? That's actually where the discussion is.
Yeah, so when I looked at the different areas of interest, for example, there are donors who are interested in certain areas. And UN, for example, has continuously pushed for the integration of these medicines. And in 2011, they produced a list of priority medicines for mothers and children. And they highlighted them in the formulations that are recommended by WHO. In 2012, they revised the list again and continuously highlighted these areas. So the donors have continuously pushed for that. But also, another interesting area, I think, which I did not talk about so much, is the integrated management of childhood illness at the community level. ICCM, Integrated Community Childhood Management of Childhood Illnesses. The medicines that have been provided by, and actually they are acknowledging these guidelines as well, are the medicines that are recommended by WHO. So we have a dual track of supply of medicines. Because the donors have interest in the community-based distribution of medicines, they have encouraged and supported community-based distribution of appropriate medicine for children and ignored the mainstream system of the public health facilities. So that's why I think I get concerned, because these things are not sustainable.
Yeah. What is your assessment of the strength of lobby groups in this country for appropriate medicines for children? Can you give a quick analysis?
Yeah, it's weak.
How strong and what we can do about it?
It's weak. But they have been stronger, for example, on newborn care, integration of newborn care in the whole system. And actually, when you look at this clinical guideline again, the newborn care is outstanding. And the medicine for the newborn care actually is well taken care of in this, and there's that emphasis. But when it comes to dosage formulations, which are appropriate for children, that's where there is a gap.
There is a gap.
And another thing is that we have to look at the interests. When they were reviewing, they interviewed people, and when they were reviewing the clinical guidelines, many of the people did not want to come and sit in the meetings because there were no allowances. So it's a challenge that, we have that kind of thinking?
Taking the example of newborn care, do you really believe that strong lobby contributes something to the implementation of policy development?
Yeah, I know where that group comes from. UNICEF has been behind, and Save the Children actually has been behind the newborn care. They have pushed, they have given a lot of money to different people to do research, and also they have created centers. And actually, School of Public Health has a center of newborn care. They are doing a lot of studies on that, and they are working along with the government. So we need another group, perhaps comprised of pharmacologists and pediatricians, to look at the formulations for children, which are child-friendly.
One of the conclusions you draw in, I think, this paper is that countries like Uganda should formally adopt, and I felt it looks more of a command, which is conceived without careful consideration of the actual issues involved in adopting policy issues. Can you comment on that?
Thank you for that, and I apologize. But at the time I was writing that, I felt, concerned. And you cannot avoid emotional things sometimes. Yeah, there is an emotional thing. And I told you at the beginning in my preamble that one of my kids was not swallowing medicines. And the pediatrician prescribed injections. We had to drive every morning and evening going there. So it was like, if there was anything that would help me not to do this, it would be useful. So it was an emotional thing, and I think I need to reconsider that. There are challenges that, and again going into the context, reading thoroughly and reading the theories, going back to the context, I would revisit my stand and say that we need to do it within the framework of the country.
Yeah. I read the word local context many times, and I noted it. I wanted you to make a comment on what you consider local context with reference to appropriate medicine for children.
Yeah, the local context is the Ugandan context. The local context is the Ugandan context, where the Ministry of Health has a small budget to procure medicines. The local context is the context, the Ugandan context, where people find it more interesting to discuss the amendment of the Article 102 of the Constitution, and they forget that actually children are dying. If we introduce a discussion about children, very few people would turn up because they are not so much interested. But when you bring something sensitive, that's when, so that's the local context. The local context is the Jinja district where I conducted the study, and you find there are no medicines available, and the supply system, NMS goes there once in a while. Most of the drugs that are on the essential medicine list are not necessarily supplied all the time, but also health workers are not trained. They are using IMCI, but they are using all the treatment charts of 2001, when actually the treatment regime has changed several times. So it's really kind of worrying, because if somebody is still looking at chloroquine in the treatment chart, these people are given these charts as the gospel route. They are like in the Bible, so they are looking at them when they are treating. Actually, one of the health workers asked me, by the way, we are supposed to use chloroquine, but it's not being brought. So you see that context.
Yeah, I know the context. Issues of limited resources, poor human resource, unstable supply chain, those issues definitely come into play in this area and should be discussed. But looking at your second article, you bring out something, the Uganda Medicines and Therapeutics Committee provide leadership
Yes.
in an effort to roll out these policies.
Yes.
The medicines and the therapeutic committees, the concept started way back and it hasn't been successful. I don't know if there is any hospital or people where you met a functional medicines and therapeutic committee. What is your take on that? Is this a fair recommendation?
Yeah, and I think it's all about the whole system. I'll give you an example. There are also quite improvement, actually, committees. These committees are proposed by the donor groups. And when they do that, they assume that people will use them the way that they designed them, without knowing that actually these health workers who are underpaid, who are not, who have too many patients to see, would have time to meet to discuss issues. But going to the committee at the ministry, it depends on how strong this committee is. Is it getting funding? Do they get funding? Not so much. It's the other departments actually which are very powerful, who attract funding. And they are the ones that drive the process. For example, when IMCI was introduced in 1995, a lot of money was pushed in. Training nationally, we had national task force. You know, they wrote down to the district. But you know, donors lost interest in IMCI and they thought the country would take it over. They did it up to now. Now, because newborn care had got a lot of funding, IMCI has been integrated with newborn care. But when you read these clinical guidelines, you realize that actually newborn care is outstanding. IMCI is in the background.
Okay. What did you mean in some of your recommendations in Article 2, negotiated policy transfer?
Yeah, negotiated in the sense that it's localized. It's really negotiated, and you know, it's not imposed. That's management. So that instead of having a dual track of supply of medicine, we have one track. These people brought this medicine to the community. They did not negotiate. They did it. They said, now we know that communities should be providing medicines. And we've seen that not working as well. They are using community-based drug distributors, whom they are not paying. But they are continuously giving facilitation in that regard. And they have forgotten the mainstream system. So negotiation would mean participation of the key stakeholders who would actually define the right path.
Okay. Study 3, I was somehow, thoughtful. You've been emphasizing Jinja as a rural area. You did work in Mulago, Jinja, and you called it rural. And I wondered whether you fared. How did you choose the study area in this particular case?
The study
on availability of medicines.
Well, that's an interesting question, and I will contextualize it actually, because this study was a part of another bigger study, and it was meant to contribute to that study. And so Jinja district was one of the areas that had been selected for by the project. There are other colleagues who did work there, and there was a thinking that actually the different studies would benefit from each other being in the same site. But also, my area work in Jinja showed that actually Jinja had a good network of health facilities, and therefore it would be a good area to assess whether the medicines for children are available.
It has a good network, but is it a true representative of a rural setting?
Well, depending on where you are, but the areas we visited are remote. The health center tools, and those health center ones are in the villages.
Okay, I think it is debatable.
Yes.
Yes, finally, the last paper on better medicine is for children in IMCI. What's your assessment of IMCI? Has it, to some extent, been a representative, what should we call, program in terms of adopting the appropriate medicines for children?
Thank you so much. My answer is no.
And why no?
Because IMCI is a good program, everybody knows that, but it is not robust enough to move along with the dynamics of change, simply because there is no funding for it. So how do we explain a situation whereby health workers were last trained on the IMCI using the 201 guidelines? So it's not robust enough. And also, when the ministry did not have enough money, they said now we are no longer interested in IMCI, we are decentralizing it to the districts. And then the districts which are receiving PhD grants cannot use the small grants to do support supervision, to do integration, to do the training. So that IMCI has been killed by other programs. It has been killed by ICCM, actually, unfortunately. It's meant to complement, ICCM is meant to complement IMCI, but actually ICCM is killing IMCI because the focus is more on these drug distributors than what is going on in the health facility.
Okay. Thank you very much, Xavier and Chair, for giving me the opportunity to have some discussion with your candidates.
Thank you very much.